Okay, welcome back, everybody. My name is Dr. Okoye Ebikapae. You can call me AB. I hope that you had a good understanding of performance improvement tools and how best to apply them, and what some of the typical challenges are in managing change. One saying you may have heard in the past is, what gets measured gets improved. And that is sometimes easier than said than done. In this session, we are joined by three seasoned leaders in data management. And may I have the pleasure to introduce to you Farouk Alemi. He is a professor of health administration and policy at George Mason University. Also to join us in this panel discussion is Mark Graban. He is an author, a speaker, and management consultant for lean improvement methodologies. And we have also here to speak to us, Johnnyvic Vadek. He is head of risk and patient safety for the Hamed Medical Corporation. These are great panelists, and may I call on them to introduce themselves to us as we start this discussion. Let me call on Farouk to introduce himself to us.
Thank you, Iyo. I am Farouk Alemi. I'm a professor at George Mason University. I spend most of my time doing research on causal analysis and new methods of statistical understanding. I do a lot of funded research on performance improvements and concepts like patterns across different data from different improvement efforts. I'm glad to be here.
Thank you. Thank you to have you. It's great to have you in this panel. Let me also have the pleasure to also call on Mark Graban to introduce himself.
Hi, my name is Mark Graban. My background is originally as an industrial engineer with an MBA, but I've worked in healthcare for the last 15 years. I've worked with health systems in North America and Europe and Asia, focused on improving healthcare, including safety and patient flow and other factors, primarily using what we usually refer to as the lean methodology.
Okay, that's great. JV, may I have the pleasure to have you introduce yourself to us?
Sure. Hi, good afternoon, everybody. My name is Johnnyvic Valdez. I'm currently the head of risk and patient safety in Hamed Medical Corporation in Doha, Qatar. My primary task is to work with enterprise management, identifying what could go wrong and how we could prevent it. So I've been involved in lots of fault modes, effects analysis, root cause analysis, and action to make sure that incidents do not reoccur. And what could we do differently so that we could prevent it from reoccurrence? Thank you.
Well, great. Let me take from what JV had just told us. His ending statement says, what can we do differently? And we can never do anything differently without data that provides the basis and the evidence to create a difference. So to speak to us, may I ask Mark to throw some light on what the role of data is in performance improvement, and why is it important to use data to drive improvement? Mark?
Yeah, well, thank you, Abby. I agree very strongly with your statement. You know, there is that common phrase, what gets measured gets managed, or what gets measured gets improved. I agree, if it were only that easy. There is a lot of measurement that occurs. We have a lot of data that tells us what the problem is, and that doesn't mean it magically gets improved. You know, improvement requires not just data, but leaders helping create a climate and environment where everyone is able to participate in improvement. I think the role of data, is really important. First off, to understand the problem. For example, how many patients fall every day or every week in our organization. And then we can use data to help understand the causes of problems or contributors to problems. Data or performance measures are critically important to understand, if we're actually improving. We don't want to just feel like we're improving. We need to demonstrate that using data. I think we want to make sure we have a good understanding between cause and effect. When we make an intervention on a system, how do we know that there's actually been a statistically meaningful improvement in performance? It can get difficult. Some data is easily easily measured in a non-controversial way. The number of infections or the number of patient falls. Some data is at best, a rough estimate. If we're looking, for example, at patient satisfaction surveys, we know not everybody responds to the survey. The survey might be biased toward those who were very upset or for those who were very happy. But either way, as we're using data, I think it's really important that we're careful, that organizations are careful, that we don't just put pressure on people to improve without having some sort of method for actually improving. If we, whether we have targets or not, that pressure sometimes leads to people, unfortunately, fudging the numbers or distorting the system in some way where it's the illusion of improvement instead of real improvement. So data can be misleading. We have to be careful about that. For example, I have a friend in Canada. He does performance improvement work at a hospital, and his wife had just delivered a baby and they were medically ready to go home. I think he said, as he told the story, it was about 9 o'clock in the evening. The hospital would not discharge them until after midnight, because if they had discharged them at 9 p.m., it would have negatively affected a metric they had where they had a goal of a certain percentage of patients were supposed to be discharged before 10 or 11 a.m. in the morning. And so there's a case where pressure to hit this measure and this target was directly interfering with what was best for the patient. Instead of getting home at a reasonable hour, they were now going to be traveling home in the middle of the night, or that bed was going to continue to be occupied until early the next morning. So, I think data is important, but data is, we might say it's necessary, but not completely sufficient, because other factors like culture and having a method for improvement really matter a lot as well.
Well, that's great to hear from you. Data is necessary, but how do we know that the data is good enough? What are the characteristics that tells us that this data, it's speaking to the improvement that we need? And what is the best way to collect this data? May I ask JV to speak to this?
Well, thank you. Building on what Mark has said, we use data to make decisions. And there are a lot of data. We have data on medical records, we have data in the safety rounds, in the environmental rounds, and all those data are just figures. It doesn't mean anything unless we translate them into information, knowledge, and wisdom. So you need to pick the data that is really relevant to what you wanted to look at. So if your issue is on compliance on hand hygiene, you just don't look at systole, diastole, or other anything else. You look at why do physicians or why do nurses or why do other staff are not washing their hands properly, or why do they do the moments of hygiene. So hence the data that you select must have these following characteristics. Number one is accurate. This data that you're collecting correct in every detail. So when we say accuracy, this is actually a crucial quality of the data, because inaccuracy will tend to bring you away or drift you away to where you wanted to improve. It must be complete. So completeness means all the information that are relevant are into the data that you wanted to look at. Reliable, it means that the data that you collected are precise, that when you collect it again, you will get the same information, not changes. And that is valid. So the data that you're collecting is really measuring the issue that you are collecting. Like, for example, like we have sphygmomanometer, which collects the blood pressure. Then suddenly you have here a column where it says the temperature. So that's not valid. And timeliness. What good do a data of 39 degrees centigrade when it was collected yesterday? So whether that data is very important, but then it is not timely. So it's not going to help the clinician or the physician in making their decisions. So the sources of data is also important. Where are you sourcing those data? Are they available? When we say availability, it could be internal. We have your patient records, we have the surveys, satisfaction reports. External, we have accreditation reports, we have the CMS, Sentinel event alerts from the Joint Commission, and those data have to be protected as well. And that's the reason why issue on accessibility is also important. So are these data readily accessible to you when you want them?
Well, that's great and interesting. Talking about qualities that make a data a good data and the relevance of the data in terms of being timely and then in terms of consistency. And we need data to really speak to what we want to do and how we want to create changes and improvement. But there's a lot of data available, and leaders are faced with making a decision. This availability of all some forms of data. I want Farouk to speak to us and to advise when should healthcare leaders act? What should they act on based on the data that becomes available?
Thank you. I want to go back to what Valdez said, that we really need to have accurate data, but that's not just enough. We need to go beyond accuracy because we are also claiming that we want to act on the data. And for action, you need to have a causal model of data. Since 19th century, statistics departments and professors have always argued that data cannot be interpreted in a causal way. But in the last 30 years, in the 21st century, we now have techniques that are different and causal in nature. And therefore, if we want to act on data, we must have a causal model of the data. We must believe that not only there is an association between the variable or change and the outcome of interest, but that association will occur in an experimental sense, in the sense that if we change it, the correlation is not just in the data, but in reality. If we make an intervention, it will change the outcome. Now, in statistics, there are 4 principles that must be met so that we can make a causal interpretation. The first one is that causes must occur before the effect. So the intervention that we have must occur before the outcome we are measuring. That is easy to do. The second one is that there must be an association between the intervention and the outcome of interest. So if we make a change, it must lead to some improvement. That is also typically done as a correlation or as a control chart showing association between the intervention and outcome. The third one is that this correlation cannot be parsimonious, that all confounding in the data is removed. For example, a common cause of the intervention and the outcome can create a parsimonious correlation. And typically this is done in statistics by stratifying the common cause and looking within the common cause for the effect. And the last point is that there must be a mechanism between our intervention and the outcome change. So it makes sense that there would be an effect. So it's not just in the data. Now, we have, when we are doing quality improvement, we have observational data. We don't have randomized studies. In observational data, there is a lot of confounding, and removing confounding is fundamental to us. Now, you may say, oh my God, this is too much statistics. And I know the events in my hand, or I can see that I made this change and the improvement occurred. Well, you don't know that improvement is due to your change. It might be because of the environment, it might be because of regulations, it might be the patient differences, it might have a number of other sources of changes. Think about when you want to lose weight and you measure your weight day in and day out. And one day your weight goes up and one day your weight goes down. It's not always what you do that changes your weight. It is a number of alternative explanations for the outcome of interest. And that is the key. Before we act, we must make sure that we have a causal model of the data.
Well, very impressive, Professor Farouk. Before we act, the data must establish a causal effect. But the data has to be correct. The data must have accuracy and consistency to establish a causal effect. May I ask JV to speak to us? What are the issues that leaders have, the challenges they face in collecting the right data? And why do we have wrong data being collected?
Thank you. Professor Farouk has mentioned a very nice and interesting causality of data in decision making. Well, leaders tend to decide before looking at the data, and I think it's an impulse wherein when we see an issue or when we see a problem coming in, come on, let's solve it before our data comes in. So that's one thing. And then the second one is, okay, let's have some data. And then when they stumble on some issues, they say, stop, okay, let's go back to number one. Right, so what are some of the issues that leaders stumble or face when they're collecting data? Number one is access to data. There are some data that you cannot just simply access. Like, for example, if you wanted to look at the electronic health record, there is an HIPPA, or there's some regulations that regulate patient confidentiality. So accessing the data, accessing health records is not as simple as opening the notebook. Say some others studies would require an ERB in order for them to, and special privileges for them to access electronic health records. Do they have authority to do that? Do they have a permission to do that? And next one is availability of the data. Some of the data are available in the electronic health record. Some are in the surveys. Some are not available. So they need to collect the data. They need to do it by themselves. And then so the question is, how much data do we need? Are we going to study everything? Are we going to study all the patients? Or we're going to get a sample of it? And so that kind of science now will have to determine, again, is 5 patients in a day in a hospital of receiving like 5,000 patients a day would be sufficient enough to represent the 5,000 hospitals, right? And so another one would be access and methods of collecting the data. How do you collect the data? Some of them would be collecting it by discrete, continuous, doing the sampling. They do the random sampling. Dr. Farouk mentioned earlier, we have the clustering sampling, conventional, stratified, and there are many ways of sampling. So a collector of data has to have a basic understanding as well. How is he collecting the data? Data is just here. The data is just in front of you. But are you going to pick every 3, every 5, or 5 in each department so that each department are equally represented? And again, I mentioned earlier of the characteristics of data, and this is also an issue, the validity and reliability. How come that a collector A, when he collected this sample, when a collector B collected the same again, it have a different outcome? So it has to be reliable, it has to be reproducible. And then validity. Sometimes some of the data that are collected represents bias. Like for example, because I'm in the nursing group and I don't want the nursing group to look bad in hand hygiene. When I see my colleagues, you're washing your hands, right? Yes, I'm washing my hands. Okay, duh, tick mark. So there we go. So those issues actually might derail you in achieving the performance improvement when not looked upon.
That's great. Actually, data should tell a story. So the data has to have accuracy, it has to have consistency, and it must be valid to tell the right story. But sometimes leaders are under pressure to act when the data that has been taken is not helpful, is not useful. Why do we think that leaders have such pressure, and how will they handle them? May I call on Mark to speak on this?
Yeah, thanks, Abby. Yeah, this puts process improvement professionals inside an organization or as outside consultants in an awkward or uncomfortable situation sometimes. You talk about the story. The statistician Donald Wheeler, who I've studied with and learned from, talks about, as Farouk mentioned, a control chart and our data, our performance measure, is what Wheeler calls the voice of the process. That is the honest, accurate voice of what's happening with our performance, whether we're trying to actively improve it or not. The story that's told by the data is true and accurate. That might not line up with the story that people want to tell. It might not line up with the story they are under pressure to tell. Again, back to control charts, and I'll share an example later on. The math is easy. The politics within an organization can be the more difficult thing to navigate. If leaders are putting us in a bad position, if they're coming to us as data analysts or process improvement people with an agenda, if they come to us and say, I want you to do some analysis to prove this intervention worked, that's not good science. And I say this as an engineer. Engineers, maybe we're not scientists, but we want to have the sort of good, valid, experimental improvement. Ideally, in some of my mentors from Toyota would emphasize always doing a small test of change. If we have an intervention that we think is going to have a positive effect on, let's say, infection rates or on hand washing and hand hygiene as a contributor to infection rates, we want to do a small test of change to validate or disprove this experiment on a small scale, because that mitigates some of the risk, right? So if we test something at a small scale and then we allow ourselves to be misled by the data, or we cherry pick data or massage the data, or there are different terms that people use, that misleads the organization. So I think there's a need for ethics. If we're being asked to prove a point that paints a narrative or paints a picture, or tells a story that might not be accurate, it might be uncomfortable, but I think there are times when there's an obligation to push back and say, look, this is what the data is actually telling us. If we're stubborn about proving that something is a success, I think that just hurts the performance of the organization over time. There's pressure, as alluded to already. I think it was JV who was talking about the need for urgency. We don't have time to collect data. Like, well, I mean, we can be rushed, or sometimes we need to be effective, which sometimes means going a little bit slower, but in a purposeful way that leads to better performance. So data are messy. Organizations can be messier. And I think we need to think about not just what are the formulas and which chart to use, but how are we navigating the environment that we're working in, and including the leaders and the culture and the politics.
Yeah, that's great. Ethics matters, and sometimes leaders are faced with solving problems urgently, and they may want to use the model of satisficing decision making and to act urgently to solve problems. So leaders may want to rely on common sense rather than the data. And this may result to problems. I know Professor Farouk have what to say to such scenarios.
Let's take what Mark said. We are doing an experiment. We make a small change and we look for an outcome. And if the outcome improved, we are happy. We improved the organization. Is that true? Not necessarily. There are many alternative explanations for why the outcome improved. One of them is the nature of the patients changed. Maybe sicker patients came, maybe less sicker patients came in the next time period. So we need to actually do risk adjustment. And that kind of risk-adjusted control chart will help us understand a little bit more if the impact of what we did is real or fake. Risk adjustment is important, but that's only one explanation of what might change the outcome. There are many causes for the outcomes we see. I like to point to an experiment that we did, an improvement effort we did many years ago on delays, excessive delays in emergency room. When you look at the excessive delays in emergency room, the common idea is very simple. You go there, you see the patient is sitting, nobody is taking care of the patient. You say, what's the problem? We need to take care of high priority patients faster. So you look at the process in the emergency room, you ask for more funding, you improve the emergency room efficiency, you make high priority patients go one way, low priority patients wait a little bit longer. All of this makes sense, except in our case, it didn't make sense. In our case, people improved the emergency room efficiency. It actually reduced the delay in getting into the hospital, excessive delay of more than 6 hours, but the improvement was fleeting. The success was fleeting. I like the book that Mark has written on this topic. Success in improvement could be very fleeting because you are addressing the wrong cause, because you're not addressing the root cause, or you're addressing one of the many causes of the event. In the emergency room that we were involved with, the true reason for why there was excessive delay had to do with not hospital beds being available, the lack of availability of hospital beds. It had nothing to do with the efficiency of the ER. So all that money, all that effort in improving the ER operations was kind of wasted. And that's the problem with common sense.
Thanks.
Let me say one other thing about common sense. I should ask each one of you why you think, let's say you are being asked to make an improvement, why you think you're smarter than all the people that came before you and tried their hand at this problem and failed. Why you think your common sense is better. It makes no sense to keep doing mistakes of others. The reason we go to data is to discipline our intuition and to come to discovery, like any scientist, real discovery of what is the true cause of this problem. What is the root cause of this problem and solve that cause.
I think you're great, Professor Farouk. Data disciplines our intuition and guide us to be able to establish a cause and effect and not rely on the common sense. That's great. And the data that it's available needs to be interpreted. Now, leaders are faced with, improvement efforts, and they have established what they want to measure, and they've implemented improvements, and the results from the data needs to be interpreted such that there is understanding of what the data is speaking to and what action to take. In these scenarios where you have leaders challenged with understanding of what the data is, what do we tell them, Mark?
Well, so, I mean, it's important when we're looking at data that we interpret data properly, correctly. People often talk about the importance of data-driven decision-making. I can think of a lot of examples where a quote-unquote data-driven decision wasn't necessarily a good decision because people weren't looking at data the right way. When we're looking at data over time, we need to be able to distinguish the difference between performance that's just fluctuating around a stable average over time and may continue to be fluctuating after we've made some attempted intervention to the system. We need to distinguish between continued fluctuation and statistically meaningful shifts in performance, hopefully sustained. So people get in trouble. This could be a mistake, or it could be a way of painting a picture that's not really accurate, is doing a simple before and after comparison. Like, I'm always suspicious of seeing just 2 data points to say, well, the number of falls changed from 8 to 4. Like, oh, well, it's cut in half. Like, well, clearly that's a huge improvement. And then the next time period, it fluctuates back to 7. And it's possible that the system's not changing. The performance is just fluctuating around an average. It's possible we've attempted an intervention that, maybe to the point Farouk made, we make a change to the emergency department and that's not getting to the root cause of the issue. So we've made a change and the number of patients waiting a long time just continues fluctuating. So, I think it's fair to say 2 data points are not a trend. If someone's trying to do just a simplistic before and after comparison, there's a lot of context missing. If they say before, the average was 8, or before we had 8 falls, is that an average over time? How much variation was there in that number? Or is that 8 just a single data point? We need to visualize data. We could do a simple run chart or a line chart, as Excel would call it. Instead of 2 data points, could we have 15 or 20 or 25 data points? Instead of last month versus this month, show me the last 24 months across the last 2 years. That gives us better context to see again, like, is it just fluctuating, what some would call common cause variation? Or have we been able to detect a meaningful shift in performance? So beyond, just a simple run chart can be very helpful. But then to help us make sure we're not just guessing of was there a statistically meaningful change or not, this is where the control chart is very helpful. There's different terminology. We could call these process behavior charts or SPC charts. There's an example that we'll pull up here. A hospital that was trying to reduce the number of patient falls. And you can see there are maybe 20 data points in the before period, where the number of falls across this organization was just fluctuating around an average of 40. Sometimes higher, sometimes lower. All of the data points are within the calculated control limits. Well, then they made an intervention. They added yellow high visibility socks to patients who were at a fall risk. And as the chart shows us, we see a visible shift. And mathematically, we say, well, there are 9 consecutive data points below the old average. That is not just fluctuation around the old average. It appears the new average is maybe 28. So we want to have we want to feel confident that there was this cause and effect relationship between adding the socks and the shift in performance. Are we at 0 yet? No, we're aiming for 0 harm. So we could look at the chart and say, well, our intervention made a significant difference, but we still need more countermeasures. We still need more improvement. But that's where I found in my work and what I've seen other organizations do. Many more data points, visualize them, use control charts to really help prove if you've impacted performance in a significant way or not, and be honest about that.
Thank you very much. That's great. JV, just like Mark made us understand, the data should be able to establish a cause and effect, and you are implementing changes based on the data. But sometimes the biggest challenge is sustaining these changes. So how do you sustain changes using data?
Well, I'll tell you, Dr. Ibi, we had a hospital wherein they saw that for the past 3 consecutive months, there's a high rejection of blood samples collected from the wards. So they did the root cause analysis, and they found out that there were about 700 or 800 new staff that were recruited to support the COVID-19 efforts. So there are 700 nurses, there are a few hundred of doctors, and they're new and they're temporary staff. So upon hearing that, the improvement team immediately conducted an awareness session. And then 1 month just after conducting the awareness session, it halved. So whatever the rate was, it was halved, and they had the early celebration. And then they stopped. They stopped collecting the data. And then they looked at another project to look at, which is patient falls. And then they look at pressure ulcer injuries. And then in the second month, they were all surprised that the data on rejected samples was higher compared to the first 3 months. And why is that so? Right. So in one of the pitfalls is early victory, celebrating early. So when you do not, so there's 2 terms used by IHI, which is embed and spread. So whenever you're doing some changes, make sure that you embed it. And how do you embed it? You continuously follow up, you continuously collect the data until you really are satisfied with your objective. That's why you have your goal. And then after several months, you reset another goal, which is improvement. For example, if you baseline is 20% and then you achieved 20%, you set another goal. As Mark have said, goal for 0. And then you get 10%, 5%, until you see that these changes are really taking in effect. There are data that will give you a chocolate effect. Chocolate, the blood sugar immediately increase, but actually the changes were not there. There was just these changes because people were afraid, and so they just complied. When you're left, they go back to the previous one. And so I'd like to take again what Mark have said on small test of change. So great thing starts from small beginnings. Start small, go big. So there are facilities wherein they do the changes in a big scenario, and then suddenly they are not able to control it. There's a lot of data, there's a lot of changes. So again, that's not sustainable. So you start with when you have a change that you want to implement, start with a small department. Uh, they said small but sweet victory. And then as you sustain it, you have another department, you have another department, little by little, little by little, until the whole facility is involved. So you don't get the whole hospital immediately or whole company immediately to get with that change that you wanted to implement.
Oh, thank you so much. You actually need to start small, and then you sustain little changes and spread the changes. That's great. But I want to take us back to what Mark mentioned earlier, that it is difficult to prove direct causation between an intervention and an outcome. How can leaders better control for external influences in data? I want Professor Farouk to speak to us.
Well, there are now new techniques available for removing the effects of external and alternative explanations for the change in the outcome. As I mentioned earlier, there are risk-adjusted control charts, which take out the effect of patient mix differences. There are also causal networks analysis, which do a better job of root cause analysis. I think the range of tools that are available to us is extraordinary. And we can go in and really understand what is happening, except many performance improvement teams are not using these tools. And it's important to go beyond flow charting and simple control charts to get to more sophisticated statistical methods that actually remove these kinds of alternative explanations of the data. I like to refer to it that we torture data until they confess. And, you know, these removal of alternative explanations is systemic. It has to be sustained and we need to make sure of it. What Valdez said is really true, that you start small. But the bigger point that he was making was that you continue. You continue until you get to zero. And very often, things go bad again because you didn't answer the real question, the real cause. By continuing, you see how frustrating it is because you improve and things don't improve afterwards. So if you look at the performance improvement data that is publicly available on all of the US hospitals through Center for Medicare and Medicaid, you see an amazing thing. You see that hospitals are not improving. Their problems persist. Everything, all the patient safety problems, leaving the scissors inside the body of the patient in a surgery, all these things continue to occur. They are not improving. But you look at the reports from the hospital, performance improvements teams are saying, oh, look, we just reduced the number of falls. We just reduced the number of infections. But you look at the infection rates reported week after week in performance improvements on the web, you see that same hospital is not reducing infection rates. So why is this difference? The difference is that performance improvement teams are taking a short-term view and they are looking at early success and they're packing their bags and going home. And that's not enough. To make systemic changes, you have to have the early success And you have to make sure the system is embedded, continuous, and that you really solve the right problem. You might have solved the wrong problem.
Yeah, that's great. Thank you so much, Farouk. Indeed, it's been great hearing from you, seasoned world leaders on performance improvement, and speaking to the very key critical issue of data management. The bedrock of performance improvement is data, and the data is what speaks to what we do, whether we're doing the right thing or we're doing the wrong thing, and whether there's really improvement based on the actions and the changes that we implemented. It's been a pleasure having you speak to us. May I have the final thoughts from our panelists? Mark, what are your final thoughts, please?
Well, one other thought that I'll share here, I have some friends who work in NHS England who are promoting the use of control charts in their board level leadership dashboards and units in different hospitals. They use a hashtag on social media that I think is great. It's hashtag plot the dots. When in doubt, visualize the data, make a run chart, better yet, use a control chart to help evaluate if there's actually been a change in the data that's statistically meaningful. And then we can use lessons I'm learning from what Farouk is talking about and what he's been writing about, how we can better determine cause and effect, and let's do so as honestly as we can. I think that's the key to moving towards zero harm and other really important goals.
Great. JV, can we hear from you?
Yeah. Data-backed, evidence-based decision-making will reduce your risk. For me, as a business person in the healthcare executive, I don't want to invest my money into elsewhere. I don't want to make a decision just out of impulse. But if I have the data, if I have the tools that I have here, and then it says here that I need to do this because this is what matters, I'll get the maximum value of the money I invest in healthcare. I can maximize every effort, resources that is available. And our resources are not that much. Resources are actually scarce, and maximizing it. And where are you maximizing it? You look at the data. Where is the data tells you to do? And when you do that, you're going to get the value out of every small resource that you have.
Yeah, that's lovely. Data guides you to maximize resources, to avoid wastages. Professor Farouk, what are your final thoughts?
I'd like to go back to the example I gave about why you think you're smarter than other people. When you face a problem and you want to make an improvement, take a look at the fact that there is data on it on the web about your hospital. There are years and years that people inside your hospitals have tried to change that, have tried to make the improvement. And ask yourself, why do you think you are smarter than all these people and all this effort? What makes you smarter? And what gives you the ability to solve this in a way that people haven't? Insights into real problems comes hard, comes for a lot of effort and a lot of thinking and a lot of trying and failing and continuing for long periods of time. And these kinds of insights need causal thinking. And that's what you need to get better at.
This been very great session, speaking to you all with your great contributions and in-depth knowledge on the topic of discussion. Thank you so much. I want to thank Mark, I want to thank you, JV, and I want to thank you, Farouk, for throwing out a lot of depth of knowledge. I hope this helps attendees who have joined us on this session. Thank you. Thank you.